My name is Dr. Zhanara Altynbekova. So today's topic for me is Parkinson plus syndrome. What is this Parkinsonism? It's a clinical syndrome presenting with any combination of bradykinesia, rest tremor, rigidity, and postural instability. So it's just clinical syndrome, and the causes can be different. And the main causes is Parkinson disease and Parkinson plus syndromes. So Parkinson disease, it's a progressive disorder characterized by degeneration and loss of dopaminergic neurons in the brain, and clinically it presents with asymmetric Parkinsonism and clear, dramatic, and sustained benefit from dopaminergic therapy. And if you talk about Parkinson plus syndrome, it's characterized by primary features of Parkinson disease, like physical examination will be like Parkinson disease, but also there will be additional features such as dementia, cognitive deficit, and cranial nerve impairment. And if we will talk about pathogenesis, there are two types of causes. It's alpha-synucleinopathies and tauopathies. So alpha-synucleinopathies include Parkinson disease, Lewy body dementia, and multiple system atrophy. And the reason is like accumulation of misfolded protein, and it forms Lewy bodies, and they start accumulate and like damaging cells. And the similar cause is like tauopathies. The cause is progressive supranuclear palsy and corticobasal degeneration. So pathophysiology also. In Lewy body dementia, there is a atrophy, particularly in the frontal lobe. In the progressive supranuclear palsy, PSP, there is a midbrain atrophy, cortical atrophy, and we can find lesion in the frontal lobe, pontomesencephalic area, and nigrostriatal-pallidal area. In MSA, there is an atrophy of olivopontal cerebral and striatonigral systems. And in the CVD, there is a frontal and basal ganglia atrophy. So there are four main syndromes that include Parkinson plus syndromes. It's dementia with Lewy bodies, progressive supranuclear palsy, multiple system atrophy, and corticobasal degeneration. And first of all, I want to do some differential diagnosis between Parkinson syndrome, Parkinson disease, and Parkinson plus syndrome. So there is some special clinical findings that will help us to differentiate. First of all is progression. If it's Parkinson disease, it will be slow progression. If Parkinson plus, it will be rapid. Neurological findings will be asymmetric in Parkinson disease and symmetric in Parkinson plus syndrome. Also, tremor is common for Parkinson disease and uncommon for Parkinson plus syndrome. Postural instability with falls will be late in Parkinson disease, early in Parkinson plus syndrome. Involvement of the autonomic nervous system will be late in Parkinson disease and early in the Parkinson plus syndrome. And also the main and really important is elevable response. It will be late in Parkinson disease and Parkinson plus syndrome, it will be early. Then it's gait. So we need to differentiate different type of gait. So in Parkinson disease, it's shuffling gait, short steps. So in Parkinson disease, it's shuffling gait. Patient has short steps, and also when you yes, there is a short steps right now here, and when you look to the arms, it's like a decreased arm swimming, and also he has postural instability, and it's hard for him to turn, so defragmentation of turns. In the MSA, so it will be ataxic gait, mostly wide base. And in the PSP, there is extended posture and quick turns. So you can see the posture is extended. And it's also called like drunken sailor gait. And it won't be like a decreased swim in the arms like in Parkinson disease. Arms will be slightly abducted. Okay. So now I want to talk about dementia with Lewy bodies. We can say that Lewy body dementia is if onset of both cognitive and motor symptoms is within 1 year. Dementia with secondary to the Parkinson disease if cognitive symptoms occurs more than 1 year after onset of the motor symptoms. And symptoms of the dementia with Lewy body includes dementia, so there will be hallucinations and also paranoia, increased sensitivity to the neuroleptic medications, and also extrapyramidal symptoms like bradykinesia, vigor, also difficult to focus and difficult to processing information. Also, it will be REM sleep behavior disorders, so acting out dreams. Progressive supranuclear palsy. So it's characterized by symptoms of Parkinsonism, like symmetric slowness and stiffness. Also, it will be early postural and gait instability with falls. It's very important because it's very specific and characterized to the PSP. Also, there will be frontal lobe abnormalities like apathy, disinhibition, impaired reasoning, and also early cognitive dysfunction, and also vertical gaze palsy. And the patient will say that he has like doubling of the vision. Next is multiple system atrophy. There are two types of it. It has predominantly Parkinson type and so coordination type. Parkinsonism type is more common, it's like 80%, and problems with coordination, it's like 20%. It has symptoms of Parkinsonism, also autonomic dysfunction. We need to take more attention to it because it will characterized by orthostatic hypotension, and systolic blood pressure will be more than 30 and or diastolic more than 15 after 3 minutes of standing. Also urinary incontinence and erectile dysfunction. Also it will have cerebellar symptoms like ataxia, tremor, dysarthria. And also there is some supportive feature. It calls captocormia. It's you can see it here. So it's abnormal flexion of the trunk appearing in the standing position, and also increasing while walking and abating in the supine position. Also, there is a Pisa syndrome characterized by lateral flexion of the trunk appearing or worsening while standing or walking, and improving with passive mobilization and supine position. The next one is corticobasilar syndrome. So it's insidious and onset and gradual progression with a minimum duration of 1 year. And it's include motor symptoms and higher cortical signs. If motor symptoms include limb rigidity, limb dystonia, limb myoclonus. Higher cortical signs include alien limb phenomenon, limb apraxia, and cortical sensory deficit. So there are two types. We can say it's probable CBS, or we can say it's possible CBS. To say that it's probable CBS, we need age of onset more than 50, plus asymmetric presentation, plus 2 motor and 2 cortical signs. To say that it's possible CBS, we can say that age of onset is not required. It can be symmetric and 1 motor and 1 cortical signs. The next one is PET scan for diagnosis and supporting. So here we can do some disease-specific patterns of altered cerebral glucose metabolism, and it will help us to differentiate between Parkinson's disease and Parkinson plus syndromes. So first one is Parkinson's disease. So the green ones and orange ones. Green regions show relative hypermetabolism. And there is increase of metabolism in the striatum, thalamus, motor cortex, and cerebellum. And decreased metabolism is in the temporal parietal occipital. The second one is MSA, so it's decreased metabolism in the striatum and cerebellum. Also in the PSP, there is decreased medial and dorsal lateral frontal cortex, caudate, thalamus, upper brainstem. And in the CVD, there is also a decrease in the frontal parietal and striatum, also asymmetric. And we need to know some supportive MRI signs for Parkinson plus syndromes. For example, MSA, it has hot cross-band sign. So it's due to the degeneration of the pontocerebral fibers. And if you talk about PSP, in the MRI, you can see, it will show midbrain atrophy, third ventricular dilation, and intact bounce. So it will give us to the classic hummingbird signs. So it's, we can see it here, like it's, I don't know, yeah. So it's like midbrain atrophy, and it will look like hummingbird signs. And also there is some Mickey Mouse sign due to midbrain atrophy. Thank you.
Well, let's see.